Hi, thank you for a great talk. So I was just wondering, going forward, I guess, there were a lot of patients that may have been HER2 zero, may have been ineligible for T-DXd. So is it, I guess, reasonable that repeat biopsies could detect these?
So Fangting, why don't you tackle that one? We didn't really touch on this, but this idea of enriching for HER2 signal over time, and I think that's related to this question about what we do with the HER2 zeros historically. How do we go find them now? Like, what's your strategy on that? That's a great question, by the way.
It's an excellent question. And I call my pathologist first, who is absolutely wonderful and awesome. And I truly, especially when it's difficult to biopsy, if it can just go back to the archive tissue and if I can diagnose an ultra low, I don't know why I want to repeat a rebiopsy. And I have been successful with that. So I actually had a patient, I had to go back to the tissue. She had a biopsy at UW, and 10 years ago, we were able to locate that and get it done. It is when there is a challenging issue when I absolutely cannot repeat it, I cannot get that information, that's when I repeat. And also we know that the HER2 IHC and we need to fix the tissue in a certain time frame, and the HER2 expression can be fragile. So if I truly need a good option, but traditionally it was a zero and I cannot get good information or data, that's when I try a rebiopsy.
Yeah, and just to go back a little bit, in the Dana-Farber experience, they published this and presented this on the podium at an ASCO not too long ago. And they basically showed that with each successive biopsy, the probability of you gaining some level of HER2 staining continued to increase. And that was in an ER negative subset, but I think all of us suspect the same is happening in an ER positive subset of patients as well. So I agree, finding patients who are eligible for this therapy is super important, even if it involves reassessing the tissue. That was a great question.